Hey friends, so today we're going to talk about hyperbilirubinemia in babies. So this occurs in infants who, within the first week of life, appear yellow. We'll go through the different types of hyperbilirubinemia and then what type of testing you should consider getting, if any. So first we'll talk about the physiology of bilirubin, how it's formed, and then we'll talk about the different pathologies, specifically indirect and then direct hyperbilirubinemia. So to start with the physiologic pathway of how bilirubin is formed. So bilirubin actually comes from the breakdown of red blood cells. When you get a red blood cell, it breaks down and forms the product heme, which eventually gets converted into biliverdin. So if you know any Spanish, verde is the color for green. So biliverdin is actually the substrate that provides green color when you have bruises that are healing several days after. So biliverdin ends up getting converted to unconjugated bilirubin, which is bound to albumin in the blood. Eventually, this gets disassociated. The unconjugated bilirubin goes to the liver, where it gets converted via this important enzyme called UDP glucuronol transferase, or UDP-GT, which will become important later. It gets converted into conjugated bilirubin, also known as direct bilirubin. This eventually makes its way through the biliary system and out into the gut. And in the gut, it is converted into these two substrates, stercobilinogen and urobilinogen. Stercobilinogen is what lends stool its brown color, and urobilinogen is what lends urine its yellow color. So you can imagine if you have an absence of either of these substrates, you're going to end up with stool that does not look brown, or acolic stool, or urine that does not look yellow, typically appears very dark. Either of those findings will be clinical findings that can indicate that there is some sort of pathology going on and that you should look into hyperbilirubinemia and often the liver in particular. So jumping right into indirect hyperbilirubinemia. So unconjugated or indirect bilirubin is a problem in infants because it has the ability to cross the blood-brain barrier and ultimately gets deposited in the brain where it can enter neurons and eventually cause cell death. In particular, this tends to affect the basal ganglia. And this process and pathology is called kernicterus. It is a preventable cause of cerebral palsy, which is why we take it so seriously when infants do have jaundice in the first days of life, even if it is physiologic jaundice. Because even with physiologic jaundice, unfortunately, this can be a potential outcome. So this is a flow chart I'll continue to refer back to. So we're going to start with this side of the chart, looking at the different causes of indirect hyperbilirubinemia, specifically focusing on these three, which tend to occur within the first week of life, and then we'll talk about the pathologic causes. So physiologic jaundice occurs in all babies. Before the baby is born, typically mom's placenta clears the bilirubin. But after birth, it's up to the baby's own hepatic system to clear bilirubin. Unfortunately, there are four problems that cause this to not be cleared as well. One, fetal hemoglobin actually breaks down faster than adult hemoglobin. So this leads to an increased source of bilirubin. And then these three problems have to do with decreased clearance of bilirubin. So one is that all of these things have to do with infant immaturity. So the enzyme that converts indirect to direct bilirubin is immature, and so it's not converting as quickly. The liver is immature, and so this leads to kind of backup of the indirect bilirubin. And then the intestines are still pretty slow in those first few days, and one, that's because the infant isn't eating as much, and as well colostrum, which is mom's milk supply in the first few days, doesn't have as much quantity as the breast milk later does. Plus, they're still clearing meconium. And as you remember, bilirubin gets cleared in the stool, and so all of these problems lead to buildup of bilirubin. This usually peaks around day of life 3 to 5. So how can we tell if this is physiologic jaundice or another type of jaundice? There are really three things that we look at. One is that this type of jaundice is never visible on day of life 1. It starts around day 2 and then peaks at least by day 5. The second is that we look at the rate of rise. So we check the bilirubin over the course of 48 hours. And as long as the rate of rise is less than 0.2 milligrams per deciliter per hour or less than 5 milligrams per deciliter per day, that is still physiologic jaundice. And then the third thing we consider is if you were to fractionate the total serum bilirubin into indirect and direct bilirubin, physiologic jaundice would never have more than 20% direct bilirubin. So the typical patient story you'll hear for physiologic jaundice is around a 3-day-old baby who is eating okay and still pooping okay and looks okay, but just looks a little bit jaundiced. So this is different from your baby who has breastfeeding jaundice, which, as it says in the name, is essentially a feeding problem. So they are not taking in enough milk, and therefore they are not pooping out the bilirubin, and so they have decreased bilirubin excretion. So the story that you'll hear is a 7-day-old baby who comes into clinic, and mom says that she's had a lot of trouble breastfeeding. The baby, when you check, is not really gaining weight, and the baby still looks jaundiced. Breast milk jaundice is, again, in the name. So we don't know exactly why breast milk jaundice happens, but we think it's as the result of something in the milk itself that is inhibiting, some of the theories say it's inhibiting the UDP-GT enzyme. But again, we don't know exactly why. Another theory is that potentially some babies who get this type of jaundice might have some heterozygosity for Gilbert syndrome or some undiagnosed minor genetic problem that results in them not being able to convert the indirect bilirubin as well, but it's not clearly understood. But this is going to be your a week-old infant who is still eating okay, still pooping okay, but still just yellow. And by that point, they should have gotten over the peak for physiologic jaundice. And so that's going to be your baby who has breast milk jaundice. Fortunately, this rarely causes kernicterus. And it may actually last for a fairly long time, potentially even as long as 12 weeks or so. So pathologic jaundice is going to be all those things that I just said physiologic jaundice is not. So it's going to be your baby who looks yellow on the first day of life. It's going to be one who has a rate of rise that's greater than 0.2 milligrams per deciliter per hour or more than 5 milligrams per deciliter per day. Or if after day of life 5, the bilirubin continues to rise. This is when you need to start thinking of what else could be going on and if there's a pathologic reason for jaundice. So now we're worried about a pathologic reason for jaundice. What sort of lab should we think about checking? There's going to be 4 main ones that we should consider. The first is going to be a CBC with reticulocyte count. The second will be a Direct Coombs test, and I'll talk about these 2 more in a second. The third will be some studies to look at the liver, so your transaminases, AST and ALT, as well as liver function tests like your albumin and coag studies. And then the fourth one you can consider would be a thyroid test, so like a TSH. So I just want to take a quick detour and just explain really quick what a reticulocyte count is and what a direct Coombs test is, as in why they matter for the pathophysiology and what we're testing for. So reticulocyte count, when we think of how red blood cells are formed, you start sort of like any cell line initially with large blast cells, which go through several phases, become reticulocytes, and then ultimately go on to become erythrocytes, which is what we see in the blood. So that's important because if you're experiencing a lot of hemolysis and your erythrocytes are decreasing, then the body will try to compensate for that and will start to produce more immature cells to replace those erythrocytes, and so that will be reflected in an elevated retic count. So if you are losing erythrocytes, the body will compensate and produce more reticulocytes, and so your retic count will be elevated. A Coombs test, on the other hand, is actually looking for antibodies in the blood. So if you have baby's blood cells and if mom's antibodies are present and attacking those cells to cause hemolysis, then a direct Coombs test can look and see if there's presence of some sort of antibody. So we add a reagent that will cause in the infant's red blood cells that have the antibody present around them to aggregate together, and that's what will show up positive for a Coombs test. So now that we know the tests for indirect hyperbilirubinemia, let's talk about the major causes of pathologic indirect hyperbilirubinemia. So I like to think of these in 3 different buckets. The biggest and most common bucket is going to be hemolysis. So that's what the Retic and the Coombs test are really aimed at helping us distinguish. So under this, I like to consider 2 different types of hemolysis. One are etiologies that cause elevated retic count only, and the other causes elevated retic with a positive Coombs test. Under elevated retic count, consider reasons why the baby might have too many red blood cells, which are turning over quickly and causing elevated production of bilirubin. So those are going to be your babies with polycythemia, for instance, infants of a diabetic mother, or infants who've had birth trauma. So like a cephalohematoma is another reason for this. Or things that are going to cause hemolysis. So either a hemolytic disorder like G6PD or sickle cell, or if the baby got a blood transfusion, say an infant in the NICU, potentially they could have a hemolytic blood transfusion reaction. Now, none of those will have a positive Coombs test because they are not associated with antibodies. So the 2 major etiologies that will cause a positive Coombs, one is Rh incompatibility. So mom had her first infant, for instance, was Rh positive, and so she developed antibodies, but that baby didn't have any problems, but now she's having her second baby who is also Rh positive, but now she's developed antibodies against the baby. So that will cause a hemolytic anemia. The second one is ABO blood type incompatibility. So a mom with blood type O typically will have antibodies against either A or B blood type. So if you have an infant who has either A or B blood type, mom's antibodies will attack those red blood cells and cause hemolysis. The second bucket will be congenital etiologies. So these are going to be problems typically with conjugation of the bilirubin from indirect to direct bilirubin. The 2 major ones we want to think about, one is Gilbert syndrome, so impaired conjugation, but this is something that is survivable, doesn't require treatment, but might cause this person to be jaundiced under times of stress, versus the more dangerous, which is Crigler-Najjar syndrome, in which the infant is either born with no UDP-GT enzyme or a partial UDP-GT enzyme. For those who do not have any enzyme, these infants will typically require a transplant. If they have a partial enzyme, sometimes you can bridge them with phenobarb. These babies also will have a normal CBC and a normal retic count. And then the third congenital etiology to consider, as you already mentioned before, would be thyroid disease. The last bucket is going to be things that cause liver congestion. which will typically be broken up into cardiac causes, so CHF, versus liver causes. So liver causes can be things that are congenital, so a portosystemic shunt, for instance, from failure of the ductus venosus to close, or things that tend to take longer to develop, so chronic hepatitis, for instance, in infants infected by hepatitis B. And any sort of chronic hepatitis can eventually lead to cirrhosis, which will cause liver congestion and failure to clear the bilirubin. So we do treat indirect hyperbilirubinemia in infants using phototherapy or exchange transfusion. So this nomogram is what we use to determine, based on how old the infant is, what the level of bilirubin is the threshold for starting these treatments. And you can see that it's actually broken into risk categories. So some infants, like premature babies, are at increased risk for hyperbilirubinemia, and so their threshold for starting phototherapy is actually lower. So let's say you have a 48-hour-old infant who has a total serum bili of about 20. You can see this puts them at above the threshold for phototherapy if they are at a medium risk or at a higher risk. But if they're a low risk full-term infant, perhaps you can just continue to watch and wait. Exchange transfusion is usually started when the total serum bili is 25 or over, and that's for infants of any age. Okay, so that's the summary on indirect hyperbilirubinemia. So let's focus next on direct hyperbilirubinemia, which can be broken out down into two main types, being things that affect the liver itself or things that are outside of the liver affecting the biliary tree. So direct hyperbilirubinemia is always pathologic, and this is defined by any baby who has a direct bilirubin that is greater than 2 milligrams per deciliter, or if you fractionate the total serum bilirubin, if it's greater than 20% of that is conjugated bilirubin, that constitutes a direct hyperbilirubinemia. As we'll talk about, the differential for this can be pretty broad, but there are some basic steps you can consider as far as diagnostic workup. So this can be broken down into imaging or into lab studies. So for imaging, usually you want to consider imaging the liver itself. So you'll most likely start with an abdominal ultrasound. More specific imaging that you can consider would be a HIDA scan or an MRCP. As far as lab studies go, kind of two big categories that you want to think about are going to be infectious, especially torch infections or bacteremia, like a neonatal infection causing a problem. And so you can think about specific studies for that, or think about inborn problems with metabolism. So consider checking, reducing sugars, or things that would make you think that this infant is having problems processing through the liver. So now I'm going to talk about some more specific etiologies for direct hyperbilirubinemia. And if you remember from the previous slide, this can be broken up into things that affect the liver itself versus things that are outside of the liver. So starting with intrahepatic causes, you want to think about what types of infections affect the liver. So these are going to be your hepatitises. Obviously, we have the hepatitis viruses, which we're all aware of, but also consider other things such as CMV, which is actually much more common in infants. HSV or enterovirus are two other infections to consider. Or sepsis, so like a GNR sepsis, such as E. coli, can also cause a liver infection. So, when you're thinking about targeted testing, this is going to be your baby who just looks really sick, is maybe vomiting, lethargic, or hypotonic. You definitely want to keep infection on your differential. Metabolic causes for intrahepatic direct hyperbilirubinemia is usually going to be your sugar problems, so galactosemia or a fructose intolerance. And then there are a few genetic problems that can also cause intrahepatic problems leading to direct hyperbilirubinemia. So cystic fibrosis is one, alpha 1 antitrypsin, and then the other two genetic enzyme problems, which we didn't talk about. So previously we talked about Gilbert syndrome and Crigler-Najjar. So those cause problems with indirect bilirubin. The two genetic problems that cause problems with direct bilirubin are Rotor syndrome and Dubin-Johnson. The main thing that distinguishes these two is actually pathologically. If you were to look at the livers, Dubin-Johnson, the liver actually looks black. The other cause for direct hyperbilirubinemia are your extrahepatic causes, so things outside of the liver parenchyma itself. Usually this tends to be biliary and frequently is an actual anatomic problem. So these will be your typically well-appearing baby, but who develops acolic stools and appears jaundiced. So the most dangerous of these is biliary atresia, where the baby just gets this progressive inflammation that eventually obliterates the biliary tree. So they essentially have no biliary tree. So by the time they're 2 to 3 weeks old, they develop those signs and symptoms of hyperbilirubinemia. And this is treated with the Kasai procedure, and eventually they typically need a transplant. So that's basically like you don't even have a biliary tree. The other problems tend to be if you have some sort of cyst or multiple cysts in the biliary tree, just because this leads to cholestasis and eventually the backup of direct bilirubin. These need to be distinguished with imaging because clinically they appear very similar. And then you can also have an external compression of the biliary tree. So let's say, for instance, a mass. This can lead to, again, direct hyperbilirubinemia. So I mentioned the Kasai procedure and just wanted to really quickly show what that entails. So basically, because your biliary tree isn't working, the liver can't get rid of the bile and the bilirubin, and so this surgical procedure actually takes the small intestine and just attaches it directly to the liver so that it can drain those products, so completely bypassing the biliary tree. So that provides a quick summary, or not so quick summary, of approaching babies with jaundice. So let's go back to our table and kind of go over the clinical scenarios that you'll be looking for. So on the indirect side, all babies have physiologic jaundice, so that'll be your 5-day-old baby who is well appearing, eating well, and pooping well but looks jaundiced. Compared to your baby who has problems feeding. So for instance, your 7-day-old jaundiced infant who is not feeding well and not pooping and is looking yellow, compared to breast milk jaundice, which is an actual problem in the milk. So for instance, a 7-day-old well-appearing, eating well baby, but who still looks jaundiced beyond the typical peak. So those are the three most common things that you'll run into, as compared to pathologic indirect hyperbilirubinemia, which is typically going to be most commonly a problem with hemolysis, for which you'll be checking a Retic count and a Direct Coombs, and considering other etiologies such as a liver problem or an inborn enzyme problem. So that's one half of your tree. The other half of the tree is looking at direct hyperbilirubinemia, which is always pathologic, and which typically means that more than 20% of your total serum bilirubin is direct bilirubin. This can be typically problems with the liver, so intrahepatic, usually infectious, but can also be metabolic or genetic problems, versus problems with your biliary tree, which is usually anatomic, so such as biliary atresia, or different cysts in the biliary tree. So that about covers it. Obviously, this is a pretty complex topic, and we covered a lot of information. We couldn't go into the details of a lot of these things, but hopefully you learned something. And good luck studying.